And don't worry, it's that the presentation and the first couple of slides are a little provocative, and it's kind of reflecting the times that we live in, and the media, and sometimes that research is that we see sometimes in both epi and randomized trials themselves. We see evidence in the media and other places of changes in our thinking about things. Even in the front page of today's Boston Globe, there was an article based on a Lancet article, which I've yet to review, on challenging the assumption that the so-called good HDL cholesterol is valuable for preventing heart disease. So things change over time, and sometimes this puts some uncertainty into the public's mind. And one of my the thesis of the talk today is that sometimes if we think more or much about research design as about statistical method and analysis, you see the second subtitle as a quote that John Willett, Judy Singer, and some others, and very well-known statisticians at Harvard, they named a chapter with this, saying that for overall validity, internal validity in terms of causal inference, we really want to know about design, research design. So we'll be talking about time series, as Seb mentioned, but also about other methods and ways in which we can try to ensure the best possible design for evaluating healthcare delivery systems' comparative effectiveness. Okay, so I just already told you that science is getting some bad press. It's not news to everybody, right? Sometimes that this does happen, and sometimes it's in this kind of form. I think many of you are aware of Ioannidis. He's the chief of medicine at Stanford, who's been writing a lot on this subject of, even in randomized trials, not being able to replicate results, and oftentimes the initial result is the strongest finding. It might be the most possible finding in a journal like the New England Journal of Medicine. And but he's been following things over time and finding that things change, and oftentimes this is kind of a cute term of phrase, the truth wears off, where the finding becomes weaker over time. And I think it's also true in epi to the extent that methods get better, and sometimes effect sizes get smaller when you do a better job of controlling for things like confounding by indication or other things. So what? And by the way, I'm going to get to the content. Is that it's hard for us as academics. I mean, I'm the first to admit that this is when I saw that front page, it kind of flipped my mind a little bit, and I wondered, is it really true? What I've been thinking for the last 20 years is wrong about good cholesterol. It's very important for the media. The media, even more than we, have trouble understanding what we produce, and they understand a little bit about controlling for things, but they don't understand research design, and when you go to policymakers and the public, it's more problematic. So one of the things I want to do actually is over the next year or so is produce a series of articles on really visualization of the importance of research design and how research design really matters in finding a closer approximation of effects. And this shrinking effects over time, I mean, it's true that the media gives, unfortunately, there has been data that shows that media gives poor quality studies equal press. And the poor quality studies, as I said before, they exaggerate effects more. So that's kind of something we just have to keep in mind. Now, actually, this is making a statement that poor research can lead to adoption. It's true, and I'm going to provide some examples, but also good research can lead to adoption of good interventions. So It's just what is the ratio and what is adopted. But it is possible for both good research, even not a Cochrane review, but a whole, but just a single study can have impacts on policy. I'm not saying that our research is adopted all the time, and it's far from it, but it does happen more than we would think, and sometimes with big consequences. So it's very important. A little bit of background is that in things like interrupted time series analysis and other quasi-experimental designs, you talk a lot about changes in delivery systems and coverage and policies from things like Care Part D to pay for performance, both national and state changes and changes in Europe. These represent massive social experiments, and oftentimes they're implemented and not well understood. I would say that's true for pay for performance, by the way. A little bit of data on that. But when talking about these changes over time, these interventions that happen naturally in countries or in states, they provide opportunities for doing comparative effectiveness or evaluation of the effects of interventions. And oftentimes the RCTs are not so feasible. Well, I think, Sebastian, you did one of a policy intervention. It's not, and of course there's the RAND health insurance experiment, but it is not the usual occurrence. I'll be promoting strong quasi-experiments, along the lines of Campbell and Slay, Cook and Campbell, Shadish, Cook and Campbell, and 75. Some of this stuff goes back 75, 80 years, more than the 20 or 25 years that I've been interested in quasi-experimental design. I will say that this area be taught better. I think, many of us here have been exposed to this, but even in doctoral programs, we don't have courses. Even in the PhD program, Health Policy at Harvard, we struggle to find courses and end up putting together reading courses that really cover that important ballpark of quasi-experimentation and causal inference. There's more on clinical trials. And then, of course, there are weaker observational designs that can be more misleading. I'll get to that in a second. But so much that, if there is an occasional question for clarification, and I'm going to leave plenty of time for a discussion. I just want to go through, I'm sorry for the next couple of slides. They're a little bit of academia, if you will. Many of these you're familiar with. You might be familiar with them using other language, the language of epidemiology or economics. But, history is simply an event occurring between the pre and the post-test. It can occur at the same time as an intervention. That would be called a co-intervention. But it's not the intervention that you're testing. For example, a pay-for-performance program. But it could affect the outcome, and therefore it's sort of like confounding. The outcome could be health. I'm going to do this a little bit more in a minute. Maturation is very similar in that it talks about the natural progression in your study population, and that could be that people become older, wiser, healthier, or sicker. And some of the best, I'm not going to show you a slide of this, but when we look at diabetes patients, the intensity of their treatment is always increasing over time. It's a natural phenomenon of reacting to patients that become a little bit more sick or in need of medication over time. And you have to control for these things. If you don't control for these things, and you're a weak design, like just before and after, you're going to mistake the natural changes as the cause of a change as an effect of the program. So there's so many. I want to write about. I said I could probably cover many different forms of selection. It could be simply that the comparison group is not comparable enough to the intervention group. They'd be more severely ill. And so this could cause different trends from before to the intervention to after the intervention, and thus bias the results. And we all know about selection. There's so many different kinds. I mean, confounding by indication, which is so important in comparative effectiveness, is a form of selection because the patient is selected to receive a certain treatment because, for example, they're sicker. That happens. Things like, I'll be showing a few more as well. This is probably the most pervasive bias, I would say, in observational or quasi-experimental research, and we're always fighting to find ways. And Sebastian, for example, and others have been looking at propensity scores to try to reduce the effect of selection on research. So, simplistic thing, looking at some of the most common forms of design. The post-only design is so rare; it's more like a case report. I don't think it's used much anymore, although it was used not that long ago to look at, for example, when pharmacists make recommendations to improve medicine use in a nursing home, does the patient's status, is it consistent with that recommendation 3 months later? Well, obviously, you have no baseline, so you have no counterfactual. You don't know what would happen in the absence of the treatment. Similarly, when you get what I call, this is the language of quasi-experimental design, post-only design with non-equivalent control group or comparison group. If you had a lot of comparison groups, that would be a cross-sectional analysis, and you'd be looking at more or less association. But I'm talking about the measuring the effects of interventions. I'm not saying at all that measures of association are not important in their own right in terms of developing hypotheses and suggesting avenues for further research. So they can be valuable. I'm just saying that in terms of causal inference, we want to be a little bit more careful. The same goes with the pre-test, post-test design, where you just have a treatment group and you look at before and after. Those three of the major biases I went through in the last slide, and there are others, but in the interest of time, I'm not going to go through all of them. You don't know if, for example, maturation or history might be, there might be a pre-existing trend, secular trends, patients are changing over time, etc. And therefore, if you just have one O, that means an observation before, and one O2 observation after. So those are really the observation, by the way. X is the intervention. I'm sorry if I didn't say that earlier. It's very, very difficult to know if anything you're seeing in terms of change is related to the intervention. And this is just showing two other designs that are usually accepted by in literature syntheses as evidence of effect of an intervention, and I'm probably the best known as the Cochrane collaboration. But I will say the first one is simply a treatment group. This is a non-equivalent comparison group with both a before and after observation. So the comparison group gives you the secular trend, the counterfactual, and does the change in the treatment group, is it greater than the control group? People at differences in economics, and they use maybe slightly different methods, but I will say that you still have the problem here of being sure that the comparison group is truly comparable. They might be different. We've had examples in difference analyses where actually the trends, I'm going to be showing them today, but the trends line before the first observation, if you look back, if you're able to look back a little further, we're different between the two groups. So now I've learned not too long ago that the Cochrane collaboration requires two comparison groups, two more. So even one single point before and one single point after versus one single point before and after in a comparison group, you may still have some problems. Whereas the time series design here, you have multiple observations before and after an intervention. It could be a single time series or a time series with a comparison series would be the strongest possible design. But usually you have like a year or two of observation before and after, and you might have 12 or 24 months of observation to look at rates, outcomes, and see if a shift, a discontinuity, as Sebastian mentioned, in either level or slope. If there's a discontinuity in the level or slope coincident with the intervention, you have very much stronger evidence of an effect, because this controls for baseline trends. I'm not going to go into all the statistics, but I refer you to a paper by Anita Wagner, W-A-G-N-E-R. I'm on the paper as well, I think, in a pharmacy journal quite a few years ago, maybe four or 5 years ago, and it's been referenced a huge number of times, because it's so well written and simply written that people can really understand it. It's basically segmented time series, segmented regression in the analysis of time series. So what you're looking for is controlling for the baseline trend in a linear fashion. Is there a rise or a fall in level, and is there a change in the slope? I'm going to get to that in a minute, because Sebastian himself did a beautiful thing. Going into now some of the weaker and the stronger designs, here's a design looking at rapid response teams trying to reduce mortality in hospitals. This is in a huge hospital network. This was, I think, associated with a IHI intervention a number of years ago. I'm not sure of that, but it looks familiar in terms of the timing of it, and also the fact that it's only a post-only design, which was done with the IHI intervention. It was called, I think, the 100,000 Lives campaign. And this, you see, it is suggestive. Do you see arrow, by the way, or no? It doesn't matter. There is a decrease in mortality post-intervention, post this start of the rapid response teams. The problem is that one, you have these question marks. What are the trends before? That's like if you had a time series analysis. What was it going up and then going down? Was it stable and then going down a little bit more? Both of those would be consistent with an effect. Or was it actually going down at the same rate or at a faster rate than it was going down mortality after the intervention, in which case this does not provide strongest evidence. And I would say actually this is close to a post-only design, except for the fact that there is a trend post. There is a post. But it does not control for history, for maturation, for selection, for all of the things I showed before. And therefore, you have to take, all you can say is that this is interesting, but doesn't really provide strong evidence of an effect. And in fact, there are data that suggests that mortality of the type they were measuring here, like from hospital-acquired infections and other things, already going down in other studies. So this is something that also IHI is re-examining right now. Another study is another weak design. The other one was post-only weak design. This is a weak design cross-sectional analysis. If you're trying to measure the effect of clinical information technologies and inpatient outcomes in the title. The conclusion of this was hospitals with automated notes and records, order entry, and clinical decision support had fewer complications, lower mortality rates, and lower costs. I don't want to go into whether this is actually true or not. A lot of this we don't know. Actually, we don't really know about things like complications and mortality and costs yet in this field. But In the study, it was a cross-sectional analysis of 41 responding hospitals based on a survey of 72. It's a question of selection bias. Secondly, there were only a requirement of 5 or more physician responses to rate the level of automation. In other words, the independent variable was based on a response by physicians of as little as 5 physicians for a given hospital rating their level of automation, and there was no validation of this of these responses as being predictive of the rate of automation or level of automation. And 160 miles of determined association, which is kind of a little bit crazy. Yet this study was, now this is an example, but it's not a good example. There are good examples too, but this is a bad example. It's an example of a study that happened right before the stimulus was passed, and was credited by the Vice President of the Commonwealth Fund as being an important influence on the passage of that legislation. So I would say that I think we would want better studies to be responsible for billions of dollars in investment by the country in this kind of intervention. And better yet, I mean, here's a completely contrary view. This is the impact of e-health on the quality and safety of care, a systematic overview. This was done by a Cochrane review team using very explicit standards where they, threw out 60%, as they always do, about 60% of the studies. And if you look at their conclusions, they say that these technologies and their cost effectiveness has yet to be demonstrated despite being frequently promoted. It's vital that future health technologies are evaluated against a comprehensive set of measures. I myself have said this in op-eds that, we really we're into a digital age, whether we like it or not. It's important that we decisions on the level of investment or the type of investments incrementally on what works. That really base things on what works and go from there. Design cross-sectional. This was a long time ago. Was the Managed Care Outcomes Project. It was published in the American Journal of Managed Care, and we reaggregated the patient-level data into cluster-level data because it actually involved only 6 managed care organizations, locations unknown all across the country. And they were trying to look at, in the x-axis, the relationship between the degree of formulary limitation, and on the y-axis, there were many y-axes. Well, this is office visits, their costs, but primarily it was cost. But all of the graphs look like this, and that is there's one outlier just above the 0 point that show very low cost or visits, and there are 4 points clustered to the right, very far away, at about 50 to 60% or 65% degree of formulary limitation. Dennis Rustig and I wrote a letter to the editor at Lancet because they had reported this in their news without any critical understanding at all of the weakness of this design. And the weakness is clear by just simply looking at that outlier and realizing that it drove the entire effect. If that outlier were not there, that line would not look like that. And as Joe Newhouse, when we used to teach together, would say, when you have a cluster of points and then 1 point and then a line between them, with the line not being supported, that's not evidence of anything. As far as the kinds of causal, I won't go into what they said, but they did say that formulary limitation led to all of these excess costs, and even in the at that time the journal press release, although nowadays this journal is like about 30 times better. Selection bias, looking at the flu vaccine and looking at epi studies and other kinds of studies. Every year, massive flu vaccination efforts are undertaken in the fall and winter. The efforts are not intended to prevent flu per se, but rather prevent hospitalization and death. That was what was stated in the inauguration of this program a number of years ago. So the vaccination are directed at people, elderly, 65 and older, who are at highest risk of these kinds of outcomes. Just to, actually, Sumit Majumdar, or Mitu Majumdar at University of Alberta, put these two slides together. He had a whole slide set just on this topic, which is very interesting. And what we know is that when you look at the randomized clinical trials, you see small to absent clinical benefit. And by itself, we would say maybe that's not persuasive. They might have been too small, etc. We see huge benefit in every cohort study ever studied and published. So what's going on there? They're very different results. And you see in the Archives of Internal Medicine stable or increasing pneumonia and death rates in the face of a 400% increase in vaccine coverage. In other words, the vaccine campaign was very effective in getting many people vaccinated, not everybody. Then someone's very smart, I would have done this, and this has been replicated a couple times. All of you are aware of this. I found the same protective effect in epi studies both in the summer and winter. In other words, in the non-flu season. So in other words, there's something about the health of the users. And you could think of it in terms of shut-ins or people who can't really get out of their house to get a flu shot are sicker than those who go to their doctor and get a flu shot. That healthy user idea, that's another selection effect, is a very important one and probably affecting research in a lot of areas. Here's a pre-post design with what's actually two pre's. You see the circles? This is on basically the United Kingdom's Pay for Performance program, and the line going up and down is the timing of the intervention. And there's 3 points in the analysis, and there's it goes from 1998 to 2003, the first 2 points, so there's no data in between. I don't understand exactly why that is. This was published in the New England Journal of Medicine, by the way. And there's, 2 years later, after the intervention, there's a slight rise. By the way, they published it with a 50 as the bottom of the axis, and when you look at it as a 0, you see the true effect is very small anyway, if you believe that. In reality, if you look, Sebastian knows this all too well, and we all know it, have done trend data. You never have straight lines anyway. This assumes straight lines. You have bumpy lines. There's error in measurement and all sorts of things. This is diabetes quality outcomes we're looking at, so there's going to be error in measurement. So we put in some, typical kinds of points. And that those typical kinds of points lead to a straight line between the pre and the ultimate post. So what we're saying is that this kind of design would not be accepted by the Cochrane collaboration as evidence. It wouldn't be included in the evidence review. The reason you need more baseline data to determine the effect of a pay-for-performance program. This is taken from Sebastian. And into that stronger design of time series analysis. You see that in the baseline before the intervention, there's a slope change. There's an upward slope, just actually occurring change. It could be changes in practice, for example, or changes in the maturation of patients. And then there's a sudden level shift downwards, presumably due to the intervention, that occurs almost immediately. And in fact, there's also a slope change after the intervention because it goes flat from a pre-existing upward trend. And by the way, this model of things being, we have a study going on now on suicidality and antidepressant use. It's very often you seem to see increased trends that are followed by an intervention where you have a level shift downward and then no more of an upward trend. The idea is that the counterfactual experience of patients had the policy not been implemented is correctly reflected by the extrapolation of the pre-policy trend. This would be even stronger with comparison series, obviously. But the idea is that the baseline trend with the little dotted points there, get an idea of like what you would expect for some period of time. The statistician here, by the way, the further out you go, the less confident you are in what the effect might be, because the confidence interval gets wider and wider. But there is a Zhang, ZJNG, if you're interested, has published a really neat study. I don't know if it was Journal of Clinical Epi. It was in a methodological journal, showing how you calculate confidence intervals at different points in time after an intervention, because that's a real problem. If you only can know the confidence interval at the time that the intervention occurs, that's more limited information than if you could know it, a year later or 6 months later. Just to show you an ITS study, this is one on pay for performance that Brian Saramaga, who's actually a fellow in our group about 2 years ago, tried to, you saw the pay for performance in diabetes, and now we're doing it on hypertension. An interrupted time series, a truly interrupted time series design where you actually look at baseline trend and is there a change in the trend. Just as background, this was a $3.2 billion funding by the NHS. It was a new contract between GPs and the Department of Health. GPs could actually earn up to 25% extra income if they met certain quality standards, which were both outcome and process of care standards. They were extremely active in this program. 99.6% participated. Surprisingly, maybe because of the economic incentive. This is the results for the one of the incentivized items, which is high blood pressure. So basically, you can see the red is the median level over time, and the fifth percentile. You can see the percentiles. They're all basically flat, or just hair increasing as would be expected over time, but there's no effect on blood pressure levels. This is almost 500,000 patients, and the data are, there are little deviations, but not that much because of the size of the sample. When you're looking even at at quarters, it's pretty good. All of the process measures all showed no effect, not even to get people who are just barely above the blood pressure, the high blood pressure mark, to get them treated, or to intensify the treatment, add antihypertensive. None of these things were done. Every single process measure, every single outcome measure showed no effect. So actually a good design can also be important in convincingly showing no effect. This is really convincingly no. This is about among the most convincingly non-effects. I don't want to show non-effects here, but we will show one or two others that are actually some effects. But here we're looking at a newly treated cohort and a treatment-established cohort, and this is basically the cumulative proportion of adverse outcomes, stroke, MI, CHF, etc., or mortality before and after pay for performance, which is the vertical line. And what is incredible is, I don't know if you can see it on your computers, but the little tiny dots between the points are confidence intervals. In other words, you can't even see the confidence intervals. The size of the sample is big enough, and this method of cumulative probability, which is similar to survival analysis, with the cumulative incidence proportion, is so powerful that the confidence in these results are very, very high, and you can see that it's basically straight lining up. There's no effect on hospitalization or stroke or those things, which you wouldn't expect, because this is a little bit of a joke. We've decided to use the new pay incentives on projects we were going to do anyway. To some extent, there was always a complaint that the physicians in the UK, the primary care practitioners, were kind of choosing their targets on the basis of what they already were doing or about to do. And I can't hear you, so I don't even know if everybody thinks this is fun. In time series versus less rigorous designs, this is something we might disagree a little bit. I'm I'm going to end this in 5 minutes so that we can actually have some questions. It's on the studies of the benzodiazepine hip fracture relationship. At the time that we did our study, and then also another study was done at UMass, like ours, which really is doing a kind of time series study on hundreds of thousands of patients where there's a sudden policy change that results in a halving of the use of benzodiazepines. But before that, since 1987, there were 24 or more studies that looked into this relationship using classical epidemiological methods. Less controls early on and more controls later on. And in these relationships, the odds ratios were going down because there were more and more controls for things like dementia, delirium, and other chronic illnesses that associated with benzodiazepine use and hip fracture. There was also conflicting results over time in the sense that, long versus short, acting half-life, specific benzodiazepines, dosage duration. But the relationship was accepted as gospel. Every drug utilization review program in the land has something about reducing benzo use because of hip fracture risk. At first for long-acting, and I don't know if they really changed it. The study by Anita Wagner, actually, that was we thanked Sebastian for actually looking over the manuscript and giving some good advice. At the top, you see a sudden drop in benzodiazepine use in the state of New York compared to New Jersey, based on a triplicate prescription relation. Which made it more difficult to prescribe benzos, and also made people worry about there being litigation or other kinds of surveillance of their practice. There was like a 50 to 60% decrease in benzo use in New York, and yet if you look at the cumulative probability again of risk of hip fracture, New York is slightly above New Jersey, which had no change in benzo use. Interestingly, this was published in the Annals of Internal Medicine, and the editors noted that wondered whether benzodiazepines prescribing may not reduce hip fractures, possibly because the two are not causally related. Incidentally, you can look up in the Archives of Internal Medicine in 2010, Becky Breisacker et al. Did a really great study, I think, on showing how when Part D stopped paying for benzos, there were one states that didn't completely pay for them, and Tennessee almost didn't pay for them at all. And they looked at it in a nursing home setting and sort of replicated our findings, except for the fact that they actually found an increase in hip fracture rate that was statistically significant, but that many of our collaborators said we should not interpret as a increased cause because it was not something we hypothesized. But people in their letters to the editor did all sorts of mechanisms for this, like people being anxious and running around the nursing home and getting into trouble and falling and fracturing their hip. So this slide simply shows, I'm going to stop in 2 minutes so I can get at least 10 minutes of questions. Differences in race, ethnicity, and the impact of the same policy on benzodiazepine use. This is kind of interesting. It shows at the top, you see the whites in green, and the bottom blacks in red or orange. And what's interesting is that black people were about half as likely to use benzodiazepines at the beginning, but their proportional reduction was greater. And it's a great method for looking at in stratified analyses at differences. This was published in Archives of Internal Medicine somewhere around 2003 or so. There's only been not that many studies on the sort of differential effect of policy by disparities in these policies. This is the last slide, pretty much. It's really a funny slide. I don't know if any of you are familiar. It's O'Connell and the BMJ in 1999. It's an Australian study. And actually, you're looking, just look at, let's look at all prescribing. This is a audit and feedback intervention. It was a randomized controlled trial of about 2,500 general practitioners in Australia, where they fed back their prescribing against guidelines and against their peers. And of course, you see these flat lines are not really effective, but what's interesting is this was both a randomized trial and a time series analysis. If you look at all of these graphs, the study and the comparison, the intervention and the control group randomized are right on top of each other. They're the red and blue lines. So you can see them separated in some of these lines just a tiny bit, but generally they're right on top of each other, these lines. And I see this as one example of showing the power of both, good randomized trial and time series analysis, and just to the extent that every single little monthly change was mirrored in the repeated measures analysis versus the, looking at the difference between the prevention and control. We actually don't need a randomized control trial here to know that there was no effect. And yet, it's very interesting that that this is one of the only studies we know of that has actually compared the two results. And last slide. I skimmed the beginning. If you're more interested, particularly in quasi-experimental design for evaluating delivery systems and comparative effectiveness, etc., this book is good, except that there are some chapters that are that go on forever, and you might want to skim them. The thing is, we're really big on graphical displays of data and looking at the raw data and not just looking at the statistical results, because sometimes problems can be found in the raw data. And I guess that's the graph is worth 1,000 p-values. So if you want to turn me off, or at least turn the others on.
Okay, well, this is John Seeger. Sebastian had to snip up for a bit, but thank you very much. Really provocative work, and I was wondering sort of where it leaves us in the sense of, it's really quite impressive how some of these time series can illustrate effects, and I'm wondering if it means that we almost have to limit inferences to things for which we have this sort of time series data, or is there hope for case control or cohort studies?
I have to sometimes ask questions like that so that I, recognize the value of other designs. I was talking more about delivery. I guess in the delivery system policy area, I think we need these kinds of designs. Okay, so I would think for things that evaluate policies or pay for performance, natural experiments, that we want designs that would pass muster in the Cochrane collaboration and then Shadis, Cook, and Campbell. But on the other hand, if you're looking at safety, drug safety, for example, you can't do this all the time. And actually, so I gave you an example where it turned out that we think that the results may not be exactly coincident with the epidemiological designs, but I think you guys have much more experience, and of course, Platt here has done a lot of safety studies, and which have been validated by other approaches. So what I'm saying is that I think that there's more room for inference when you think about the impacts of policies and delivery systems and things like that. Talking about drug safety, I think this is what we've got. It's the best we can do. You guys are, yourselves, trying to do it in the best way possible. So that I guess, constantly searching for ways to reduce confounding by indication and all these things is really important. I'm not saying that that we shouldn't use epi. I hope I didn't. I gave that example. It might have suggested that I thought that that wouldn't use these designs for those sorts of studies. But I think that it's really what we have, and so I think it's reasonable.
All right, thanks. I did have a question also about the benzodiazepine example, and I noticed on the figure of slides from Anita Wagner's paper, the month-by-month use of benzodiazepine is shown before and after the intervention, but when you show the hip fracture occurrence, it's done cumulative incidence, and I was wondering if there's a rationale for why one on a cumulative and one is a month-by-month figure.
Oh, yeah. I'm sorry, I didn't explain that. Good question. It's the scale. If you look at the y-axis, time series, I get to all of it. I'm really trying to just show some of the uses of the method without going into all of the methodological details, but series is good when you have stable measures over time. And there are times like hospital infections, and it's a rare infection. You have it jumping all over the place, and you really have no idea, even with a time series analysis, what's going on. So for those cases where we had here, we had over 100,000 people here, and Becky Sucker also used a similar method, sort of like a segmented survival analysis. It's actually looking at the change in the incidence rate, in a way, in the cumulative probability associated with the intervention. We have a much more stable measure because it's so rare. So it's survival analysis. When you do deaths, you do it always as survival analysis. You don't do it as a time series, usually, unless you have some gigantic database, because it won't be as stable. It'll be jumping around so much that you won't get a good measure of the baseline trend, for example.
There's also a question that came in from the audience online. Let's see. The question is, can you speak to findings in observational data where the regression results show considerable clinical effect based on point estimate, but non-significant p-value, and vice versa, significant p but tiny point estimate? I'm not sure I can understand the question itself.
I'm a little tired because we had faculty review day today, so you have to just a little bit. I think is it clinical versus statistical significance, sort of, or?
That's sort of how I interpret it. A large effect, but significantly insignificant is the other way around.
Good point. All right, so I think that has not much to do with any analysis that you do. You have to state ahead of time. In a short talk today, I guess we didn't do that, but for example, looking at this benzo that you brought us to, that 60% drop in benzo use is certainly a clinically significant reduction. What would be significant? It's a really hard. I would hear. Can that person actually speak? Or?
Liz, everybody unmuted?
Everyone muted at this time.
Well, either question or any other questions from the audience that we have?
One thing is, I think some people determine ahead of time what they consider clinically significant effect. Suppose it's an important thing to do, especially in randomized trials. I think the big example is alendrolite with fracture risk. I believe going back, it's people reporting a 50% reduction in risk, but it was going from 2 to 1%, and that maybe because of the importance of the outcome, several percentage point effect might be considered clinically significant. I think it would take a group of smart clinicians to get together to determine that, as well as economists determining the cost of such outcomes. So it's a really question. In quasi-experimental design, we're usually looking at hypotheses like, what is the effect of high deductible health plans on adherence? We're actually doing a study like that now. And we're not sure. Oftentimes the find data from previous studies is almost non-existent, which is the case. So it's really hard to know what to expect exactly. So we've not had too many problems with that question, because we generally speaking, our studies have either shown no effect, and that's often interesting, or an effect that's sizable and interesting. It's kind of funny. Now, one study that we did was trying to get patients and docs together to use beta blockers after acute myocardial infarction through the HMO Research Network 4 or 5 years ago, actually. There was an effect that was significant. That was about 1 to 2%. Maybe it was more than that. A couple of percent increase in rate of use of beta blockers after acute myocardial infarction. And they did a cost effectiveness analysis to a certain extent. The answer was simply mailing patient letters from the clinician saying, you took this drug, you should really stay on this drug. And it was very cheap, and they got a couple percent increase in the prescribing outcome. But when you look at the randomized trials, it resulted in somewhat meaningful increase in survival. So the big thing was, it was clinically significant and small.
That's a useful expansion on that question, and at this point we're at the end, and so I'd like to thank you for the presentation, and thank the audience for participating, and we'll be off next month, and we'll see you then. We'll be back in July with the next version of this learning series.
Thank you.